Hello, friends. If you or someone you love is depressed or has low mood, you might think that you have depression or major depressive disorder, but that might not be the case. There's lots of mimics. So hang with me as I get to the bottom of this and we go through some surprising alternatives. And just a reminder, this is not individualized medical advice. This is just educational content. So depression is a very complicated phenomena. It sounds like it's just one thing, and it is just one word. But in fact, a better way to think about it is more like a symptom like chest pain. And just like chest pain, there can be many causes of depression. In the case of chest pain, it could be a heart attack, it could be your lungs, it could be costochondritis, which is related to the skeletal muscles and bones around your chest. In the same way, depression is more of a set of symptoms and it can have multiple causes. So let's jump into them. One of the most common causes of low mood or depression is a side effect of substance use or substance use disorder. For example, with cannabis use, especially if it's a very high amount or if it's chronic, one of the core features is decreased motivation. And decreased motivation or anhedonia is also another core feature of depression. So sometimes parts of them can look like each other, which is different from the euphoria experience, which is also possible with substance use. In addition, chronic alcohol use similarly, in the moment of consumption and the next couple of hours, people tend to have elevated mood, but with chronic use, we see chronic depression and chronic low mood being induced, with characteristic changes in the brain over time, and in some cases even mimicking dementia or alcohol-induced dementia. In addition, chronic opioid use has a similar effect, where if you have surgery and then you get some opioid medications, like oxycodone, when you're in a lot of pain, the opioid use is not going to be much of a risk of addiction or changes in your brain chronically, but the opioid receptors in your brain and your nervous system change, and that change predisposes people to have depression and makes people have less of an enjoyment in life as a result of the chronic use of opioids. Another possible cause of depression is withdrawal from substance use. Withdrawal means after you've taken the thing, or after you've been exposed to the thing, there's a rebound effect that has its own properties and its own characteristic states and its own physiology. So for example, with cocaine, people have euphoria and a bunch of other experiences like hyperactivity. And then in withdrawal, people have a crash. And that crash can mimic a major depressive episode. Similarly, with heroin, you have a similar rebound effect, and with alcohol as well, because withdrawal is often the opposite experience, and also for amphetamines. You have a similar psychology in withdrawal. All right, and also another cause is a personality disorder called borderline personality disorder. And what's unique here is that part of the phenomenology or experience of borderline personality disorder includes low moods. And with this disorder, other characteristic symptoms like chronic emptiness, impulsivity, self-injurious behavior, difficulty with identity, and other complex psychological states. So you want to always think of personality disorders as well. And it's often hard to rule this out unless you really get to know somebody. In addition, we want to think also of the side effects of medication. So a lot of medications you might be on for various other medical things can cause depression as a side effect. Specifically, let's start with corticosteroids. For example, imagine you have a rheumatological condition and you have joint pain and your doctor prescribes prednisone. Especially if you're on this at a high dose or you take it for a long time, it can itself induce various psychiatric symptoms, including depression. If you have acne and you're on something like Accutane, this is a well-characterized side effect of that, as well as seizure medicines, anticonvulsants, such as Topamax and Keppra, which are also prescribed for other conditions. For example, Topamax could be a weight loss medicine. In addition, hormonal contraceptives, especially when you have a lot of the progesterone component. Now, in a typical menstrual cycle, dysphoric mood and difficulty with mood is more common in the second half of the cycle when women get closer to menstruation, not just in PMS, but throughout that second half of the cycle. And progesterone is more common, is at a higher level in the second half of the cycle. So there's a connection there. And it makes sense that when you give exogenous or external progesterone to someone, they're more likely to have difficulty with mood. Long-term benzodiazepine use. Benzodiazepines are things like Valium, Ativan, clonazepam. These medications can induce low mood in withdrawal, just like other substances, and they actually bind to the same receptors as alcohol. which is why both alcohol and benzodiazepines have an anti-anxiety effect. Same thing with long-term opioid use with morphine and oxycodone. Those opioid receptors are going to get fatigued, and then people are going to have less of an experience of positive emotion during the day with chronic use. So it's generally a bad idea to be on opioids for long term. And interferons, for example, if you're getting treatment for multiple sclerosis or hepatitis, people will often get interferon alpha, and that's an immune modulator which has depression as a side effect. So you want to think of all these medicines, including things like blood pressure medicines like clonidine, propranolol, atenolol. What these do is they affect norepinephrine, and norepinephrine is one of the neurotransmitters that affects mood. So it all makes sense here. So keep that in mind. Check your medication list. In addition, there's a bunch of vitamin deficiencies that can cause depression. B12 deficiency, B9 deficiency or folic acid deficiency, B6, pyridoxine deficiency, and niacin deficiency, B, as well as vitamin D, which is correlated with depression, and there's less evidence that it actually causes depression. But these B vitamins are really important because they're often involved with the biochemical reactions in the formation of various neurotransmitters. And before we checked for these kinds of deficiencies, many patients in hospitals who are chronically in the hospital actually had vitamin deficiencies. So now it's really important to get these checked. Another pathway to depression is through your thyroid, specifically hypo or low thyroid function, or low thyroid function. That's what the word hypo means, HYPO. And when your thyroid is underactive, you're going to have depression. And so this is one of the most important things to screen out before you start thinking that you have major depressive disorder, for example. So keep that in mind. In addition, Parkinson's disease is an unfortunate and common disorder in the elderly. And one of the core deficits in Parkinson's disease is dopamine signaling or dopaminergic function, specifically in the substantia nigra, which is a part of the brain. Now, when you have low dopamine levels in Parkinson's disease, you're going to also get depression because dopamine is really important for your mood. But of course, you don't want too much of it because then you're going to start hallucinating, but you don't want too little of it either. So there's a finely calibrated amount of dopamine that's needed in the body. And you want to also think of Parkinson's disease, especially if you have any motor symptoms associated with the low mood. In addition, similarly, dementias profoundly change the brain and its circuitry. And one of the side effects can be depression. For example, in Alzheimer's dementia, the frontal lobe is often impacted. And when the frontal lobe is impacted, this will damage a lot of the areas related to mood regulation, as well as our ability to interpret our thoughts and feelings in a healthier way. Similarly, there's something called vascular dementia, and this is where a lot of the blood vessels are affected, and you have these mini strokes in the brain, and there's something called a vascular depression that can be entirely attributed to vascular dementia. So having a good head MRI or head CT scan can be sometimes very helpful in the process of working up a low mood that's very hard to understand. All right, in addition, we also want to think of just normal grief responses because when somebody you love dies, of course you're not going to be having a party. You're going to feel profound dysphoria. And a lot of the things that we'll experience are similar to what we have in a major depressive episode. But the question, is it bereavement or is it depression? So you want to think about that because there's certainly a time to grieve the loss of a loved one. But at the same time, it can go overboard, and that's when you may want to treat complicated bereavement just like you would depression, and that's where you need a really skilled clinician to figure that out with you. All right? And in addition, then we can have regular old major depressive disorder, which is probably the first thing you may have thought of when you first saw this video. But here, the key thing is that the symptoms of depression have to last for at least 2 weeks, most of the day, every day, most of the day, most days of the 2 weeks. And you have to have more than just low mood. You need to have a lot of other symptoms. And there's a certain criteria that you have to work through. And these things include insomnia, low appetite, psychomotor retardation or low movement, suicidal ideation, and other symptoms. So keep this in mind as well, but don't automatically jump to this as the answer to everything, because it's certainly more complicated than it seems at first. And again, depression is more than just feeling sad or blue. You have to think about whether it's interfering with your life, affecting your work and school and relationships. When it gets to that level of distress plus dysfunction, you want to ask yourself, has it been going on for 2 or more weeks in a row? And now you're in a position where you might call it major depressive disorder. In addition, there's something called bipolar disorder, which you've probably heard of, which is vastly overdiagnosed. And most people who think they have bipolar disorder actually don't. In order to qualify, you need to have had a manic episode, which makes you bipolar 1, or a hypomanic episode, which is like a manic episode but not as extreme. And you typically would have periods of low mood and then periods of mania or hypomania. And what's interesting is that the majority of the time, people with bipolar disorder hang out in the depressed phase. So they're not often in the manic or hypomanic phase. And bipolar depression is something that's really important to treat and to diagnose accurately because the treatments are totally different. And if you treat bipolar disorder with an SSRI, like Prozac or Zoloft, you're probably going in the wrong direction. And you want to have a very careful discussion with a clinician about that. Always think of bipolar depression versus major depressive disorder, which is often called unipolar depression, because those two are not the same thing by any means, even though they both share the word depression. In addition, there's something called cyclothymic disorder, which is persistent depressive symptoms that alternates with periods of hypomanic symptoms. And so there's this up and down phase that doesn't go all the way to extreme mania. It stays hypomanic, but also persists with depressive symptoms. And so this is a complicated thing to diagnose. You want to think of this one as well. In addition, there's various other conditions that show depression. For example, schizoaffective disorder, which is a combination between having psychotic symptoms like hallucinations, hearing voices, and paranoia, along with characteristic features of major depressive disorder or depression. So there's lots of flavors of depression out there. And similarly, there's something called adjustment disorder, which can present with a depressed mood. So if you have a terrible experience, you have a stressor, and then say I respond to that in a way that impairs my functioning, but I don't really meet the criteria for depression or PTSD, but I'm still struggling, and a lot of my experience is with a depressed mood, it might be an adjustment disorder. And the key thing here is that these are time limited, meaning they're not expected to go on and on. All right. Now, similarly, there's something called dysthymia, which is persistent depressive disorder. And here you have someone who has a chronic ongoing experience of depression, but it's not getting to the point where it's really severe. It's this low level chronic mini depression. Not to trivialize it, but just to say that the severity and the quantification of the symptoms is typically less, and it persists for 2 years or more. This is another flavor of a depressive disorder that typically doesn't meet the criteria for a full major depressive episode. Okay? And in addition, Cushing syndrome is a medical condition where there's too much cortisol in your body. And there's multiple causes of Cushing syndrome. However, when you have too much cortisol in your body, you're going to have a lot of these characteristic changes here. A larger belly, fat pad on the back of the neck, changes in the skin, thinning of the extremities, the arms and legs, a roundness in the face. Those are characteristic changes if you just give someone a lot of cortisol. Say you injected somebody with a lot of cortisol, you would eventually have them develop into a Cushingoid appearance with something resembling Cushing syndrome over time eventually. And the reason this affects mood is because cortisol inherently is going to be destructive to parts of the brain and the mood regulation system and a lot of other neurochemistry. And a chronic stress response, if somebody's chronically in a fight or flight state, for example, somebody in PTSD or panic disorder, they're going to be having a lot of chronic stress for a long time. And that high level of cortisol can also induce them into having a major depressive disorder, or it can mimic depression. So getting cortisol checked out is really important. So as you can see here, there's so many various factors here, and I hope this has been really helpful for you, those you love, to try to figure out what's been going on. If you like this and you want to see more like this, please subscribe and like this. And if you want to keep up with things like this, please join my free newsletter at medicalwisdom.org. Thanks so much. Take care.